Welcome, ladies and gentlemen, to today's tutorial. Today we are going to look at the ulnar nerve. Remember that in the anterior compartment of the forearm as well as the hand, two nerves are actually going to give what you call motor supply to the muscles as well as give sensory supply to the skin around the area. Now we've seen one of those muscles being the median nerve. We saw that the median nerve was actually supplying most of the flexors and pronators of the forearm. Actually more those ones which are more related to the lateral aspect. And that is why they're able to help in what we call cross movement of the hand, making them colloquially be referred to as what we call the labrum nerve. Today we are interested in the fine movements of the hand. And for the fine movement of the hand, such as writing, it will actually be coming from the cancase of the ulnar nerve. Now, this ulnar nerve can therefore be referred to as the musician's nerve. It can also be referred to as the funny nerve because of the relation to what we call the medial epicondyle posteriorly. And that is why, making the humerus, often be referred to as what we call the funny bone. Now, this, ulnar nerve is actually going to come as continuation of what we call the medial cord of the brachial plexus. So please go and visit one of those videos that I've done on the brachial plexus, its formation. Yes, also look at that of the ulnar nerve that I've done. Actually look at the arm muscle, forearm muscles, as well as muscle intrinsic muscles of the hand, which will help you give you better understanding of what we are actually going to do. Now, therefore, because it's a continuation of the medial cord of the brachial plexus, its root value will be C8 and T1 ventral rami. But what happens is that it also receives what we call communication branch, coming from what we call C7 fibers. Therefore, by way of its root value, we can say it's coming from actually C7, C8, and of course T1 nerves, ventral rami of actually the brachial plexus. Now, we will get to know that because it's going to come from actually the medial cord, it's going to be related to what we call the axillary artery. So without much ado, let's begin our journey with the ulnar nerve. So this is the ulnar nerve actually. The ulnar nerve is going to begin in the axilla. It's going to be related to actually the third part of the brachial plexus, actually medial to the third part of the brachial plexus. But over the years, there will also be what we call the axillary vein. Therefore, it will be sandwiched between the axillary artery and the axillary vein. Remember that in the axilla, it's not going to give any branch. In the armpit, it's not going to give any branch. Remember that beyond this teres major muscle, the axillary artery, which is in the armpit, changes its name to become the brachial artery. The artery that is going to supply the arm, calling it brachial artery of the arm. Therefore, it will also be related medially to this axillary artery as well. Now, this muscle is known as, this muscle that you find here is known as the coracobrachialis muscle. This coracobrachialis muscle inserts on the medial aspect of the shaft of the humerus. At where it inserts, this ulnar nerve actually pierces through the medial intermuscular septum. Now, this medial intermuscular septum is actually separating the muscles of the anterior and posterior compartment of the arm. So it pierces it and changes its course, now turning posteriorly as it is turning posteriorly. Remember again that in the arm, the ulnar nerve is not going to give any branch to supply any of these muscles. Neither is it going to give cutaneous sensation to the skin around the area. So it goes posteriorly to what we call the medial epicondyle. Now, this medial epicondyle will be covered by a fascia, creating a tunnel through which this ulnar nerve will go through it. And that tunnel is known as cubital tunnel, so that it goes through it. Now, when it gets into the elbow area, it gives articular branch. Usually we give articular branch to supply, the joints area. Now, if this median nerve over here, as it passes posteriorly to what we call the medial epicondyle, when it is tickled, then it results in that kind of sharp, sensation that you feel through the hand. Okay, tingling that you feel through the hand. And that is why we call it the funny nerve, making the bone also be referred to as the funny bone. Again, if there is inflammation, okay, if let's say one hits the table or an object with the area where the median nerve, is, well, the median nerve is actually palpable at this, channel that is created behind the medial epicondyle. Okay, that is palpable over here. So once it hits something, then it can be stimulated, okay, resulting in that kind of tingling, sensations. So even if there's inflammation, medial epicondylitis, yes, it can also, affect this nerve, cause injury to this nerve, some form of injury. Now, if this nerve is injured around this area, then what happens is that all the motor supply to these muscles will also be absent. These muscles become weak, they will atrophy, or they will waste, resulting in weakness in the functions that they are going to perform. So that is one thing that we have to know over here. Now, from the elbow joint, it enters, actually into the forearm. Remember that the ulnar nerve is not a content of the cubital fossa. Now, for it to enter the forearm, it goes posteriorly and enters into the two hairs of what we call the flexor, carpi ulnaris. This muscle, the two hairs of flexor carpi ulnaris. Remember that in the median nerve, we saw that it entered, the forearm by actually passing through the two hairs of what we call the pronator teres. This time around, the ulnar nerve will enter the forearm by passing through the two hairs of flexor carpi ulnaris. Now, as it passes through it, it gives supply, muscular supply to what we call the flexor carpi ulnaris. Beyond that, in the forearm, it also gives supply to this muscle, which we call it flexor digitorum profundus. Remember, we've seen, please visit that video of mine. Yes, I've done all those videos. But remember that by the end of the day, these tendons are actually flexor digitorum superficialis, which was split, giving passage to these, tendons, which represent the flexor digitorum profundus. Please visit that video to get more understanding. Now, just as it runs in the forearm, it lies actually medial to what we call the ulnar artery. This is the ulnar artery, the red one, ulnar artery. And just about 5 centimeters, okay, to the wrist area, it gives off this branch, okay, it gives off this branch, which is known as the dorsal cutaneous nerve, okay, dorsal cutaneous nerve or branch of the ulnar nerve, So this dorsal cutaneous nerve, okay, branch is actually going to supply the dorsum of the hand, okay, around this area, as well as supplying the dorsal part of the little finger together with the nail bed, and 1/2, okay, medial part of what we call the skin, okay, around the dorsum of the hand, as well as, of course, the nail bed. So we're going to supply this area. So that will be the cutaneous sensation that is going to supply, okay, it. Now, apart from this, just about 2 centimeters, and to enter what we call the wrist area, it also gives another branch. This branch, which is known as the palmar cutaneous branch. Palmar cutaneous branch. Now, this palmar cutaneous branch, yes, as its name suggests, is going to supply the palmar area, okay, the hypothenar region, skin over here, as well as, of course, the skin around the little finger over here, and 1/2 of the skin around medial portion of the skin of the ring finger. Remember that for the median nerve, there was no dorsal cutaneous branch. There was only the palmar cutaneous branch that we saw. All right, so now for the now, as it comes, it crosses this tunnel, okay, this tunnel over here, which is known as the Guillon's tunnel or the Guillon's canal. But this Guyon's canal is going to serve as content, okay, going to provide, passage for actually both the, ulnar artery as well as, the ulnar nerve. Therefore, we call this tunnel also the ulnar tunnel or the ulnar canal, so that the nerve will continue its journey. Now, in that, just after crossing it, it actually gives off this branch, which is the deep branch of the ulnar nerve. Deep branch. This deep branch will actually run, okay, lateral to this pisiform bone, and it will go deep into what we call the pisohamate ligament. Pisohamate ligament, to supply the muscles of the tena eminence, of the hypotenar eminence. This is the hypotenar eminence. And the muscles of the hypotenar eminence, yes, will include what we call the flexor digitorum. So let me start with the abductor. So this is the abductor digitorum, okay? Sorry, it's going to be abductor, digiti minimi for the little finger, abductor digiti minimi, flexor digiti minimi. Then we also have what we call the opponents digiti minimi. Okay, these muscles are going to get their motor supply from the deep branch of the ulnar nerve, Now, this one, in addition, we also have what we call palmaris brevis, being part of the hypotenar group. This palmaris brevis is actually subcutaneous. It's one of the muscles that we call them subcutaneous, muscles. They have subcutaneous insertions or attachments, and we call them panniculus, canosus. Panniculus canosus. Now, these panniculus canosus muscles, yes, apart from the palmaris brevis, we also have what we call the platysma muscle, as well as the dartos muscle. When they contract, they just cause wrinkling, yes, around the area. So if it's palmaris brevis, or wrinkling around the neck area, or wrinkling, yes, on the scrotal skin. So that's what we are going to find with these ones. Now, apart from this, we're also going to give, the motor supply to what we call the medial two lumbricals. Now, we know that there are 4 lumbricals. Now, the medial two lumbricals is going to get their motor supply from the deep branch of the ulnar nerve. We saw that the lateral two was getting their motor supply from the median nerve. Now, remember that these lumbricals, what they do is that they cause what they call flexion at the metacarpal phalangeal joint and extension at both proximal and distal interphalangeal joints. Therefore, if these ones, okay, if they become affected, then they will result in the opposite, so that there will be extension, okay, or even hyperextension at what we call the metacarpal, phalangeal joint, and then there will be what we call the, flexion, extension. So it's going to be this way at both, proximal and distal interphalangeal joints. And that is what we call claw hand. We saw median nerve claw hand, which, affected actually 3 of these nerves. Now, the other 2 will actually be coming from these ones. So for actually complete, claw hand, then there should be injury to both, the, ulnar nerve as well as, the median nerve. So that's one thing. Now, in addition to these ones, yes, there's also going to be what we call, they are also going to supply what we call the palmar, interosseous, and of course the dorsal interosseous muscles. We know that the palmar interosseous, yes, will help us with the mnemonic PAD, palmar interosseous, and PAD is for adduction. So bringing the fingers, all the fingers closer to the middle finger, adduction. Now, by so doing, if you want to test for this whether the nerve, supplied it is actually intact, of course the ulnar nerve, then you have to ask the patient to do this. Yes, you place, paper in between. Yes, of course the, index finger, and of course let's say the middle finger, and then you ask the patient to, of course, still adduct, and you try not to, move it. Try to move it and see if the patient can still hold on to it, the paper. So this is how we are able to do it. If it fails to actually make a grips onto the paper, then of course there's weakness, for the, palmar, interosseous, for PAD, for adduction. Now, we also look at, the dorsal interosseous. For the dorsal interosseous, yes, the mnemonic, dab, for abduction, taking it away. So you ask the patient to abduct the fingers, this way, to see if you're able to. So you tell the patient to abduct the fingers. So if you're able to do it, then of course there's no injury. But if not, then of course the muscles are weak because of injury to the ulnar nerve. Now, one other thing that we have to know is that, yes, in addition to these ones, they're also going to give, this nerve is going to terminate by supplying what we call the abductor pollicis, muscle. The adductor pollicis, adduct, so bringing the thumb closer. So adductor pollicis, bringing the thumb closer to the rest of the ligaments. So adductor pollicis muscle will also be supplied by the deep branch of the ulnar nerve. By doing this test, okay, by just doing this, and that test is what we call the Foreman test. The Foreman test. Foreman test is that you ask the patient to hold the paper this way, and then you ask the patient, okay, to make a grip onto it. Shouldn't allow it to be pulled. So as the tries to pull it this way, but if it is positive, it will still remain there. Sorry, if it's negative, okay, it's saying that the adductor pollicis is not it's not weak, losing its strength by way of wasting, because it's not getting what motor supply from the ulnar nerve. Then it will remain adducted this way as it is being pulled. But if there is weakness in there, then what happens that the patient will tend to flex. So as you've seen, it will flex the thumb at the interphalangeal joint of the thumb this way, making use of actually the anterior interosseous nerve, which is actually a branch of the median nerve. Actually from the flexor pollicis longus, it will making use of that one, and that is a positive test, meaning that the adductor pollicis is actually weak from loss of innervation from the ulnar nerve, Now, the next thing that we are going to see is that we also see that therefore this nerve, it can be compressed in, of course, the ulnar tunnel. It can be compressed in the ulnar canal. So it can be compressed as well here. So if it's compressed here, then it means this area will be spared. The muscles which are supposed to be supplied here will be spared. Of course, again, that of the cutaneous branches will be spared because they are not in this canal. But of course, beyond that, it's also going to give this muscle, which is the superficial branch. This is the deep muscle, which we looked at. It will also give the superficial branch. Now, the deep branch will also give supply to actually the medial head of the flexor, pollicis brevis. The medial head of the flexor pollicis brevis, which is actually part of the thenar group. Remember that the thenar muscles are actually supplied by what we call the median nerve. But the medial head of the flexor pollicis brevis will be getting its motor supply from actually the deep branch of the ulnar nerve. So please, let's get that one in mind. Now, this superficial branch, yes, will run superficial, so it won't go through, this, flexor, it won't go beneath the flexor retinaculum. Remember that, yes, we said that after, the deep branch will run lateral, to the pisiform, it will go deep to the pisohamate ligament, to supply these muscles deeper. But the superficial one will run superficial to what we call the flexor retinaculum. Therefore, it's not really a content of what we call the, the carpal tunnel. It's not a content of it. Therefore, carpal tunnel syndrome wouldn't result in injury to what we call the ulnar nerve, unlike in the case of the median nerve. So that is what we are going to see. So it will run superficial, but actually it will be covered by extension coming from the flexor retinaculum, modified extension fibers from it, and that is what we call the carpal ligament, carpal volar ligament, or volar carpal ligament. We'll cover it actually, and it will enter, the hand area, giving actually, supply to this area of the skin, as well as the muscles over here, giving those kind of branches. So This was actually a quick tutorial, yes, regarding this kind of ulnar nerve. Thank you very much for your audience.